So we saw the tonsils in the Waldeyer's ring, and just let me make sure. So now let's answer this question. Where are the tonsils present? Yes, in the pharynx. Remember the nasopharynx and the oropharynx. The tubal tonsil and the pharyngeal tonsil in the nasopharynx, the palatine and lingual in the oropharynx. So here let's look at typical tonsillar tissue, and I'm using palatine tonsil as an example. So one of the first things you see in the tonsil is that it is covered by epithelium because it's present in the pharynx. So it has a surface which faces the pharynx. So there is an epithelial covering which you see here. So in the case of tonsils which are present in the nasopharynx, the epithelium will be based on whatever the nasopharyngeal epithelium is, which is very similar to respiratory epithelium. So in the nasopharynx, the epithelium would be pseudostratified, ciliated columnar epithelium. And here, the palatine tonsil, which is present in the oropharynx, here the epithelium is stratified, squamous, non-keratinized. The lingual tonsil will also have the same kind of epithelium as palatine because they're both present in the oropharynx. What is also typical of the tonsils is that the epithelium dips into little sort of valleys or grooves which are known as crypts. So here you see crypts present, and so the epithelium lines the crypts. There is no cortex or medulla, but just under the epithelium, all the lymphocytes and the macrophages, they kind of get together, they aggregate, and they form these round structures which are known as lymph nodules, or also known as lymph follicles. They're also known as lymph follicles. And often when you look at tonsil, this is not part of the tonsillar tissue, but often because you can see these mucous glands and skeletal muscle, you might think it's part of the tonsillar tissue. It's not. It's just because tonsils lie in the pharynx where you have pharyngeal skeletal muscle and you have a lot of mucous glands. That's why whenever you take a slide of the tonsil, you often see these two structures along with it. But that's not part of the tonsil, okay? So what is part is epithelium, crypts, the presence of these lymph follicles. And since tonsils tend to get infected very often, what you'll have in the lymph follicle is a central area which might be lighter staining. So you can see this central area here is lighter staining. That is known as the germinal center. And the reason the germinal center is lighter staining is because it is made up, if you remember, lymphocytes were cells which had very little cytoplasm. They mainly had a nucleus, and the nucleus was kind of purplish or dark blue, purplish in color. But and this is the cytoplasm. In the germinal center, you have cells which are known as lymphoblasts. And these have a nucleus, but they also have a lot more cytoplasm. So the cytoplasm is pale blue in color. So because of the presence of more cytoplasm, that area looks lighter stained compared to the periphery. Okay? So germinal center is usually seen in the center of a follicle. It signifies the presence of infection, because if there's an infection, then the lymphoblasts will begin to form more lymphocytes to combat the infection. So in order for that to happen, they'll begin to multiply. So whenever you see a germinal center, that means infection is present. So here are some of the salient features of tonsils. They are present in the pharynx. The epithelium is, depending where it is, pseudostratified or stratified squamous. They have crypts, they have follicles, and the follicles may have germinal centers. Let's look at this question. Why is the epithelium different in these two areas, in the lingual tonsil and different from that of the pharyngeal and tubal tonsil? Very good. Yes, because of where they are present. So if they are in the nasopharynx, they automatically get the epithelium of the nasopharynx. In the oropharynx, they get the epithelium of the oropharynx. Excellent. Okay, now you did thymus initially and now you've done tonsil. So if you were to differentiate them histologically, which of these answers would hold true? All the statements hold true. See, the thymus has only the thymus between these two. We are only talking about these two. Only the thymus has a cortex and medulla. The tonsil has epithelium and crypt. So automatically these two statements are correct. And remember, the thymus does not have germinal centers. Only the tonsil has germinal centers. Okay, so all the statements are true. Now, if the palatine tonsil was enlarged, what do you think would be the effect? So think here, where is it present? What would be the problem? The person would have difficulty swallowing. Yes, that's right. Remember, it is present in the oropharynx. And you swallow, the oropharynx is, and let's go back to look at the slides. The oropharynx is just behind the oral cavity, and obviously when you swallow over here, the food will go down. Now if this is swollen, it's going to cause a difficulty in swallowing. If the pharyngeal tonsil was enlarged, which is when adenoids, then you'd have difficulty breathing. We expect that everybody is a nose breather, not a mouth breather. And if the tubal tonsil was enlarged, what would it do? It's lying on top of the eustachian tube. So it would compress the eustachian tube. And then these people might have ear infections because the eustachian tube connects the middle ear cavity with the nasopharynx. So ear infections become common if that area is blocked. Okay. Even if the lingual tonsil was enlarged, usually it isn't. But if it was really big, this also they would have problems with swallowing. Okay. Now let's look at lymph nodes. So first we look at the gross picture of lymph nodes. As I told you, lymph nodes are present all over the body. I mentioned in certain areas they are aggregated. You see huge collections. For example, in the inguinal area, here in the groin, so they are known as inguinal lymph nodes. Then you see them in the axilla, the axillary lymph nodes. You see them in the neck area. They're called the cervical lymph nodes. They drain all the areas. For example, the scalp and the neck and face drain to cervical. Most of the upper limb and the thorax drains into axillary. The lower limb drains into the inguinal. And then inside the abdominal cavity, you have a bunch of lymph nodes which are present with the various organs. So, depending on where they are present, we colic lymph nodes with the colon or mesenteric lymph nodes with the small intestine. And then these lymph nodes you can see are connected to each other by lymph vessels. And these lymph vessels, you can notice all of them, they drain into big channels. So there are two main big channels. The first one is what is called the thoracic duct. It begins from a small little pocket or dilated sac which is present in the abdomen. So this thoracic duct begins from there, It travels through the abdomen into the thorax. It goes all the way up into, because lymph, remember, lymph is flowing up, right, towards the heart because it has to drain into veins. And it goes up, and then it opens on the left side. It opens into the junction between the subclavian internal jugular. So it opens into a vein. Remember, lymph all finally went into a vein. So this thoracic duct, it drains, as you can see, most of the body. So look at what all it drains. So, it drains below the diaphragm, it drains everything, right and left sides of the body. And then in the thoracic region, above the diaphragm, it drains the left half of the body. So the left thorax, the left upper limb, and the left side of head and neck. Can you see that? That's what the thoracic duct is draining. So how about this right side then? The right side has a separate lymphatic duct, which is known as the right lymphatic duct. So this drains the right side of the head, the right upper limb, and the right side of the thorax. And it also opens into a vein on the symmetrically. So it opens between the internal jugular and subclavian at the junction there. It opens there, the right lymphatic duct, okay? So the thoracic duct area of drainage, you can see, is really, really vast. That of the right lymphatic duct is much slower. That's how finally all of the lymph is brought back into the circulation, because it pours it into the veins. Now let's look, if you were to take one lymph node and you took a section of the lymph node, you will notice that it has a very thick capsule on the outside, which is just made of connective tissue. And there are many vessels which open, lymph vessels which open into it. So you can see these lymph vessels which are going towards the lymph node. These lymph vessels are known as afferent lymph vessels. And then coming out from the lymph node are fewer efferent lymph vessels. How this helps is, because lymph is flowing, a lot of lymph flows into this lymph node. It has to travel through here, through this entire lymphatic tissue. And then because it only has a few exits, what happens, lymph kind of stays in the lymph node for a while. When it stays there, it makes the lymphocytes come in contact with any pathogens or cell debris or anything they need to come in contact with and take care of. So it keeps the lymph longer in the lymph node, making these cells come in contact with them, and so it can do its job. That's why you have more afferent and fewer efferent lymph nodes. Also, if you notice the shape of the lymph node, look, it's kind of bean-shaped or kidney-shaped. So there is this convex area, and this area here is known as the hilum. This concave, like little indented portion is known as the hilum, where you have these efferent lymph vessels, and you also actually have blood vessels. So you have veins which come out, and you'll have arteries which will supply it. So you'll have arteries as well, arteries going in. I also want you to pay attention. Lymph is very similar to veins. So it has valves. So look at these lymphatic vessels. They have valves so that lymph only flows towards the heart, especially in the lower lymph nodes, the lymph nodes which have to go against, lymph vessels which have to go against gravity. Skeletal muscle activity, like veins, is also important for squeezing lymph vessels and pushing the blood up. Inspiration, when you inspire, the thoracic pressure decreases and it sucks the blood up. Same way it helps to suck lymph up. So all the things that help veins take the blood back to the heart help lymph vessels also. Now here, if you look at a cross section of a lymph node, you will notice under the capsule there's a little sort of space present, which is called the subcapsular sinus. It's nothing else but just the space where the lymph kind of flows in from here. It flows in and it just percolates slowly. Then the lymph node, like the thymus, is divided into a cortex and a medulla. So the cortex is the outer area. The medulla is the central area. So this is cortex, that is medulla. In the cortex, this capsule sends in little septae. So you can see these septae going in and dividing it into smaller areas. And here you see in the capsule, the lymph, and these septae are also called trabeculae, or also known as septae. And in the cortex, the lymphoid tissue, the lymphocytes and macrophages, they are aggregated as round structures which are known as lymph follicles, or also known as lymph nodules. So here you can see these are all the lymph follicles. So you can see these lymph follicles present there. When you come to the medulla, the lymphocytes and macrophages, instead of being aggregated as round structures, what they do is they kind of come down and get together as more rod-like or linear structures like this. So they look very cord-like or rod-like. So they are known as medullary cords. So can you see these? These are the medullary cords. They're not round. And in between the medullary cords, you have a lot of spaces present. So imagine if you have medullary cords like this, you have these spaces present, which are just dilated lymph channels. These are known as medullary sinuses. So this helps because lymph first comes in, passes through this subcapsular sinus, then passes through here, then it goes into the medulla in the sinuses. So all, it collects in all these areas so that making the lymphocytes come in contact with anything that needs to be taken care of before the lymph exits. Okay? So this is the structure of a lymph node in cross section. Yes.
Would you say that when you're talking about things that assist in like venous return, also increase lymph return, would you say that somebody who has poor venous return would likely have poor lymph return?
Someone who has poor venous return, whether that person will have poor lymph return, not necessarily so, because they could have poor venous return if they have varicose veins. Okay. But they don't necessarily have to have a problem. Everything else may be working, but the lymph would be normal, Okay. So yeah. So not necessarily, no. So let's look here, just a quick view on this. So this has no audio, but it's just showing you how blood percolates into the interstitial spaces. These are proteins picked up by lymphocytes, taken back from the interstitial spaces. So they pass through lymph vessels. And here they meet a lymph node. So this is an afferent lymph vessel. Inside the lymph node, see more afferent, fewer efferents. And you can see here, they pass in and then they'll pass out. You can also notice the blood vessels there. After going through a lymph node through efferent, then they go into the thoracic duct and finally into a vein and back into the heart. And then there is the right lymphatic duct on the right side. Okay? So here again, cortex and medulla, follicles or nodule, cortex, medullary cords and sinuses in the medulla. So typical features of a lymph node. Okay, so I already kind of told you this question. Lymphatic vessels are very similar to veins. So what is factors responsible for movement of lymph? So I mentioned, so it's really all of this, including pulsations of arteries, because very often they lie close to lymph nodes, to lymphatic vessels and veins, and that helps too. Okay. Now, if suppose your big toe was infected, which areas would be affected? Or which areas would the lymph nodes be swollen? Ooh, lymph nodes all over the body. No, sorry, good. Yes, the regional lymph nodes. Yes, very good. Yeah, because lymph nodes just drain areas they are close to. So just the regional. If you had cervical lymph node enlargement, you would expect some problem in the head and neck area, scalp infection, something in the tonsils, something like that. Yes, regional lymph nodes. Okay, what is the direction of lymph flow in the thoracic duct? Very good. From abdomen to thorax. Remember, this is going from below upwards towards the heart. So sometimes, when you get questions, read the question carefully. You might get a choice where one part of the choice is correct, but the second part may be wrong. So, if you're looking at it and you think, oh, everything is correct, read it carefully because, it might just say that the lymph in thoracic duct or the thoracic duct goes from thorax into abdomen instead of saying from abdomen into thorax. Okay. Let's look at lymph nodules or lymph follicles, and these are discrete lymph nodules or discrete lymph follicles which are present as part of other organs, and these are seen anywhere in the bronchus, in the respiratory tract, gastrointestinal tract. In the small intestine, they are known as Peyer's patches. When they are present in the small intestine, they are given a special name. They are called Peyer's patches. Elsewhere in the gastrointestinal tract, you see them, but they don't get a special name. You can see it in the genitourinary tract, anything that's exposed to the outside. You want lymph follicles to be there, lymphatic tissue, so that it can kind of help take care of any infection. And this, you can see, this is a huge lymph nodule, and look at this lighter stained area here. This is a germinal center, so obviously infection was present. So you can see this area here. And this is what it would look like if you took a piece of the intestine where you can see these little follicles like this. Now, where would you not find lymph nodules or these lymph follicles? Epidermis, yes. You do see the gastrointestinal tract. The Peyer's patch is part of the gastrointestinal tract. I did say that anything exposed to the outside, and epidermis is exposed to the outside. But remember, when we started lymphatic tissue, I told you that anything which has a blood supply has lymphatic drainage, the exceptions being bone marrow and the brain. Epithelium is avascular. There is no blood supply. So epidermis, you don't see lymphatic follicles. You might see it in the dermis, but not in the epidermis. Okay, so epidermis is the answer here. Then the next lymphatic organ is the spleen, the largest of the lymph organs. This is present in the left hypochondrium of the 9 abdominal regions. If you remember the 9 abdominal regions from ANP1, so we had these 9 regions. Do you remember them? So this one was right hypochondrium. This was called epigastrium. Left hypochondrium. This was called umbilical. This was hypogastrium. These two were lumbar. This was right iliac and this was left iliac. So the spleen is present here in the left hypochondriac area. Very, very large. It's related to the 9th, 10th and 11th ribs on the left side. Completely covered by peritoneum. Extremely vascular organ. It's related to a lot of abdominal structures which you can see here. So here's the spleen. So notice all the structures it is related to. It is related here, it is related to the stomach. So that's why you have this gastric area. So the stomach lies on top of the spleen. It is related to the left kidney. So notice the left kidney and the left suprarenal. So that's why this is called the renal area. The colon, the large intestine also passes up. It goes down like this and comes this way. So the large intestine also is related here. It's often where it turns and becomes the descending colon. This is often called the splenic flexure, just to tell you that it's related to the spleen. So that's why you have the colic area, as you can see here in this part. The pancreas, the tail, this part is called the tail of the pancreas. That is very closely related here. This is the area where the tail of the pancreas, this is the tail of the pancreas, very closely related to the spleen. And the spleen is really a very vascular structure. So you have to know all these, because if the spleen is injured, when it enlarges, normally you cannot feel the spleen. It has to enlarge to 2 times its size. It has to double its size, twice its size, in order for you to actually be able to feel it under the costal margin. And, any slight sort of hard hit or something can rupture an enlarged spleen. It's very, very soft, so you can't stitch it up. So you have to remove the spleen. So you then have to be careful that you know all these organs which are close by, and you don't want to catch hold of this tail of the pancreas when you're removing the spleen, because the tail of the pancreas has a lot of the endocrine portion of the pancreas. So if you remove that, you can make the patient diabetic, apart from the fact that you open up the pancreas and all the digestive enzymes will begin to pour out. Okay? One of the functions of the spleen is it's called the graveyard of red blood cells. So it filters the blood, takes care of all the dying or dead red blood cells, and it kind of recirculates the pigments and the iron and all back into circulation. In the fetus, it was an area where blood cells were manufactured, but not after birth. The bone marrow takes care of that. And here, so once you've paid attention to this, so imagine if you, so here are some of the features. Lies in the right hypochondrium, related to 7th to 9th rib, completely covered by peritoneum, must enlarge twice in order to palpate or feel it. Its function is to take care of the dying red blood cells. And here is the histology of the spleen. So the spleen does not have any cortex or medulla. So there's no cortex or medulla. It does have a capsule. So if we draw the spleen, there is a capsule. And what the capsule does, the capsule, again, wherever you have a capsule, it sends in these little septae inside, or these are known as septae or trabeculae, again, same thing. Not well seen here is a small trabeculum that you see, but usually inside you'll see it's as very large, you can actually see them as large pink structures like this, because they're cut in all different directions. So that's what a trabeculum will look like inside. And blood vessels will be seen inside it, because blood vessels go into the trabeculae in order to reach inside. And in the spleen, what you see is that one is it gives a very red and blue appearance. And you see areas where it's blue and collected as lymph follicles. And other areas it's kind of just, it's got red and blue over here. The areas where you find where it's blue and collected in the form of follicles, you call it white pulp. You just don't call it follicles, you call it white pulp. And this is made up of lymphocytes and macrophages. So the cells, the lymphocytes and macrophages, aggregate together forming a nodule or a follicle, and we just call it white pulp. In the other area here, which is the red pulp, in the red pulp you find those red blood cells, the ones which are come to die, and there's also a lot of blood flowing there. And you'll find lymphocytes, monocytes, macrophages, all of these will also be present, but they are all present loosely. They are not kind of aggregated together in the form of a follicle. Okay, so that is very typical of spleen, having a red pulp and white pulp. Okay, no cortex or medulla. So no cortex or medulla, scattered follicles, which we call white pulp, and then there are free RBCs, macrophages, lymphocytes, which is the area which we call red pulp. Now, because of the fact that the spleen is such a soft organ, very close to the ribs, it can be injured quite frequently. So here, if we are looking at a side view, so here's the spleen. I remember it was covered by peritoneum. So here's the peritoneal cavity. The spleen is related to the 9th, 10th and 11th ribs. So it's also related because it's on the left side, it's also related to the left pleural cavity. This was the left pleural cavity. So imagine if someone had a stab wound going through that, you can understand that it can open up the pleural cavity, injure the diaphragm, because this part here, it's lying below the diaphragm. This here is the diaphragm. And then it enters the peritoneal cavity and then slashes the spleen. It could also injure a lot of organs close by which are present, okay, based on where the injury is. But you can see the pleural cavity could also be injured. So not only do you have an abdominal problem, you now have breathing problems also in addition to that. So in a splenic injury, based on that picture which you saw, which is of the following is least likely to be injured? So that's why looking at these PowerPoint slides is really important. Yes, it's the duodenum. The pleural cavity is likely to be injured. I just showed you in the previous slide here. Look at this, the pleural cavity. So this is the left side, so left pleural cavity. But if you look up here at these organs that the spleen, this is the duodenum. See, notice this? So far away from the spleen. So you had a choice of pleural cavity, yes. Left kidney, pancreas, all these are close by. The duodenum is so far away. This is on the right side. So this is least likely to be injured, okay? So that's why the duodenum was the answer to this question. So let's look now, just do a bit of review. Which of the following would be typical of thymic histology? And here read the question, and I'm saying typical of thymic histology. Okay, the correct answer is number 2. And here's why. The thymus does have cortex and medulla. But remember, the lymph node also has cortex and medulla. So it's not typical of the thymus because the lymph node also has cortex and medulla. The presence of those pink onion skin-like structures, remember I told you, Hassel's corpuscles, that is typical of the thymus because that's only present in the thymus. You see that? Epithelium, of course, is only in the tonsils. And red pulp is present in the spleen. So therefore, the presence of it, when you say typical, that means only the thymus has it. Nothing else has it. Cortex and medulla, well, the lymph node has. So you can't use that. Okay. So presence of Hassel's corpuscles, which are pink onion skin-like structures. So let's say you're looking at a slide of a lymph node. How would you be able to tell if there is an infection? Yes, very good. And I said slide, so you can't see pus in the slides and you can't, and not necessarily by bacteria. So you can see the pale staining germinal centers. Yes.